Okay, so I think why don't we move on to our second topic. There are two elements to this. One is a new revised ISS staging system, which is coming along, will be coming out in the Journal of Clinical Oncology shortly. And then what was quite an emphasis at this summit here in Vienna, how should we be approaching the use of a personalized medicine approach to treatment, particularly in the clinical trial setting right now? And so if we look first of all at the new revised international staging system developed primarily by Antonio Palumbo and the Italian team, but with significant collaborations. The simple way of looking at this is that they took the traditional ISS staging system based upon serum beta-2 microglobulin and serum albumin, and added to that the cytogenetic and FISH information and LDH. And so basically, if you have standard abnormal chromosomes or negative FISH findings and normal LDH, that would enhance the sensitivity in the stage 1, and obviously for the ISS stage 3, high risk plus a high LDH would give you an enhanced stage 3 assessment. And so it's just a refinement, and you can see that the curves are pretty smooth. It does give quite good discrimination between these three patient groups. And so the question is, at this point in 2015, with these kinds of diagnostic and prognostic tests, how do you view this? I mean, this is a minor improvement. It's certainly something that we can add in relatively easily within a clinical trial setting. But how do you view this sort of enhancement? Ola, what about you?
Well, I think it's beautiful work. I think the curves are smooth. I do also think that in 2015 we have all these new drugs and we have a lot of data, if you look back to see how powerful therapies have been applied to different risk groups. I think the difference in the past with powerful drugs compared to now is that the new powerful drugs are not necessarily as toxic. So I think you could justify in the past that you could hold back with the powerful drugs because of toxicity. You could spare those patients with a better prognosis and maybe say that you shouldn't give them all the toxicity. But now you have these powerful drugs that are not so toxic. So my opinion is that you should give the best drugs to all the patients and not scale back because that the biology is less adverse. And my bottom line is that I think those individuals have the highest likelihood of benefiting from the best therapy.
Right.
On the other hand, I do think that this information is highly important for the interpretation of data on clinical trials. So to study results and to stratify, to make sure that the two arms, if you have a randomized study, are equally balanced, so the results are not driven by factors like this. So that's how I view it. And on a clinical note, I use it more as a prognostic factor to understand the trajectory of the disease, but I would not use it for therapy myself. I don't know what Paul and Joe.
Yes, so I take that point, and I think in talking to patients, I think that this information is very helpful in guiding the way that you might present the baseline information when all those results come back from the lab and you're meeting with the patient. This is very helpful, obviously.
Yeah, no, I agree. I mean, I agree and I disagree with Ola, but I mean, I agree with the concept that sometimes I tell patients there's two stages of myeloma.
Yes.
The stage that needs to be treated and the stage that can be watched. Right?
Okay.
But so I agree that it's not necessarily guiding therapy but this is very excellent work. And I think we all recognize that myeloma is more than just beta-2 microglobulin and albumin. I mean, it's time that we had cytogenetics. In fact, instead of calling it the revised ISS, because you know me, I'm the acronym guy, I've come up with a new acronym for this.
Really?
BLISS.
Blitz.
BLISS. So B is for the bone marrow cytogenetics. The L is for the LDH, and the ISS is the same ISS as before. Right? So and I'm not sure this is quite blissful, but we'll take bliss for now.
Okay, I think Antonio might be quite pleased.
Yeah, Antonio, I mean, that's one thing Antonio and I might agree on. But on the other hand, to Ola's point that theoretically, now that the drugs are less toxic, which is wonderful, and I support that, that we should necessarily then still have as an aggressive approach in lower risk patients sounds good, but until we have that evidence, I'm not sure that we can say that for sure.
Right.
But I definitely agree with him that this isn't going to change therapy, I don't think, our therapeutic approach, but it's going to give us a better informed prognostic tool. And that's what the ISS usually has been used for,
Right.
and helpful in clinical trials, you're right, because we can capture this information in trials. Because as we know, different systems have incorporated MRD, for example, plus ISS or now BLIS, and those kinds of complex tools may be helpful in certain situations. But I think it is a step forward, and I'm thankful that we've been able to collect that information.
Right.
Well, I think it is useful. I think that certainly from the point of view of therapeutic choices, I agree entirely with Ola that it makes no sense to be therapeutically parsimonious in an incurable disease. Well, what it means is that for your higher risk patients you need to do more, but for your quote-unquote standard risk patients you need to do as much as you reasonably can. So I would be very struck that, for example, in the group who have adverse cytogenetics, I would want to make sure that in my combination approach, I had drugs that optimally targeted mutational thrust. For example, I'd make sure proteasome inhibition was part of it. I would consider participation in trials in which, for example, there might be a monoclonal antibody that might be part of that study, which, as we know, is agnostic to adverse cytogenetics in a very favorable way. So I think there are implications from this revised staging system that will provide us with not just a clue to how these patients may do, but over time may guide us in therapeutic choices, recognizing that I agree with you, Joe, right now, would this versus another make me not offer a 3-drug regimen? No, other considerations would guide me, tolerability, convenience, and so forth. So I think that it's an important step forward. I totally agree that it takes us above ISS. I will say, though, that, in credit to the ISS, what a remarkable system that provided us with a real bedside tool. And I think that, enormous credit to Phil Gripe and the team who originally did that work, and enormous credit, as always, to Antonio and the IMWG for going up this next step. I think, interestingly enough, from a patient perspective, this is very tangible as well. And I think I'm struck that some of my patients are getting rather confused by gene expression profiling, 70 versus 100. What does it mean? Is it the sword of Damocles? Right. Well, this is much more practical and I think more helpful in that regard. And I always say that a fool with a new tool is still a fool. And at the end of the day, we need to know what these tools really tell us before we can start to absolutely guide patients in one direction or another. So I think that's kind of helpful as we frame it. But I agree with you, Joe and Ola. This is an important step forward.
So what I'm going to do now is to switch from the simple to the more complex. And so what was a topic at the summit and invoked a lot of discussion was, where are we with personalized medicine? And so if we switch to a much higher gear and look at where are we at the molecular level in understanding myeloma, from a simplistic standpoint, it sounds great. You identify the genetic lesion, and then you come up with a test and a treatment for that. Very simple, right? Well, not so simple. The summary of the genome sequencing, for example, for myeloma shows that there is no unifying mutation. The most frequently occurring mutation is found in only 30% of patients. And there's a shift from thinking about those mutations to maybe pathways that maybe contain collections of mutations. So a lot of discussion about that. And then if there is what has been discussed as an actionable mutation, one in which we might have some treatment option, such as the BRAF mutation here, which occurs in 4% of myeloma patients. How should we approach that? And what has actually been the initial experience in targeting this kind of a mutation? And then what about what has become a big topic, clonal tides, intraclonal heterogeneity, the fluctuations at baseline, and over time as different therapies and sequencing of drugs has occurred. And so there are ways of trying to capture this, and one system that has been developed in the Mayo system is to come up with a custom mutation panel, which is targeted towards some of the more common mutations that have been observed. And you can look at these in different ways, the recurrent mutations actionable genes, the pathways, and then those targeting drug resistance to particular drugs. And so several ways of looking at it. And so a lot of discussion about whether this would be a good tool to integrate into upcoming clinical trials. And so at the summit here, and I'm going to ask our panel just 2 or 3 of the questions that came up. So at the summit, this was a listing of topics for discussion. And so maybe we can just start at the top here. So should this kind of mutational analysis approach be included now in clinical trials? Are we to the point where we need to be starting to look at this? We talked about ISS, bliss, but are we here? Who wants to take this one first?
Me? Oh, thank you. Wow, this is a difficult one for sure. Well, I mean, we know from these studies that have been published the past 18 months that probably the standard patients diagnosed with myeloma has maybe 10 or so more parallel myelomas going on in the body at the same time, molecularly.
Yes.
And when we treat, I do think that there could be some of these myelomas that we actually already are curing, while some are not.
Yes.
And that's when the recurrent disease comes back. And they are so molecularly different. So now, coming back to your questions here, do you need to study this in every trial? It's very expensive to do it. So I think my answer to that is no. But I do think for newly diagnosed studies, I think it's important. And I think for certain studies, that could be a reason to do longitudinal monitoring. So I think we need to do some more thinking and defining where we want to go with these very expensive technologies, because they are almost as expensive as the drugs.
Yes.
So we don't have unlimited resources. We're going to talk about that later.
Yes.
And that applies also to the trials. And the trials, they are bringing up the cost for the drugs when they eventually hit the market.
Yes.
So we have to be thoughtful when we design these types of studies, I think.
Yeah, I agree with you. I don't think we're quite ready to introduce them in the vast majority of trials. I think
Right.
we're still at the collection phase. I mean, even as you've listed here, you know, there are different ways of doing this. And I think what we're learning is that myeloma is so complex. There's so many genes turned on and turned off that I think what we need is more collection of this information. It's not quite ready for prime time. And I think you made an excellent point, Ola, that what we're learning in the work that we've done and presented at this last ASH and have published is it's one thing to get a photograph of a patient's disease at one stage or at one point in their career, myeloma career, but it changes over time. And that can be very helpful. That's where we can see it. Certain genes disappear and then come back. You know, the concept of clonal tiding, or of certain ones that later in the stage of the disease tend to be a little bit more turned on, like the BRAF mutations tend to be a more later event. So because right now the results of what we're finding don't immediately intervene with treatment, I'm not sure it's quite ready to incorporate into trials. But if larger centers that have large tissue banks can collect this information and we get a better sense of the different pathways, you know, we think about our actionable drugs or actionable mutations as we've mentioned. Sadly, that's still in a very small percentage of people, but hopefully with time, if more drugs can be matched to those pathways, we'll have more for them. So I'm excited about the fact that we're understanding the biology more and that it's going to help us with time. But this is not like some other diseases like, let's say, chronic myelogenous leukemia, where the vast majority of patients have a single gene that's affected, you know, in the Philadelphia chromosome, and we can jump in at one point. So I'd be worried about us spending so much effort and energy in clinical trials, but in different centers that have the expertise, I think they'll engender enough information to then be shared so that we can do it on a perhaps more broad level in years from now.
Yeah. No, I agree, Joe. I think the important thing is that, and I do think in clinical trials the information's useful. Again, the point, or hopefully will be. So I think collecting, and you know, perhaps not necessarily processing everything to the point that you make about cost, but at the same time collecting data. And I think that the concluding statement here, Brian, is very provocative. Yes. Targeting mutations is futile because the emergence of resistant clones will continue. I think that is true, but as we all know, one of the arguments has been, well, now you've got the monoclonal antibodies, you don't have to worry about this, surely, because it's going to just take care of it. Not true. We know that the antibodies have been greatly successful. We've seen super responses, but we certainly don't know that it's the sort of game changer where targeting mutations is going to be futile. To your point, I'm struck that we do have drugs, for example, that target BRAF mutation. My own personal experience from patients who participated in those trials is their responses are transient, interestingly. So I think they're short-lived and they have to be part of combinatorial strategies. So I think that targeting mutations is not futile. I think it is worthwhile, but again, it's a matter of the practical. So I think collecting it in clinical trials is important. Clinical practice, I completely agree with you. I think we have to wait and see. And in terms of the preferred method, Brian, I mean, I defer to the experts in the field there, and myself being something of a novice when it comes to these particular technologies, but I'm assuming the technologies that will make the most sense are the most robust, the cheapest, and the most reliable in terms of reproducibility and validity.
So, yeah.
One aspect I would like to add to this is that I agree with the thinking to bank samples.
Exactly.
That's important. So I do also think that not only to select drugs could this be good for, so this could also be good for monitoring low-level disease, obviously, and we even set the diagnosis. So we have done work in the laboratory when we did the bone marrow aspirates, we lysed the cells, we took out the DNA, we sequenced the tumors, and then with half a milliliter of plasma, we picked up the same DNA signature.
Right.
So you set the diagnosis in a very small amount of DNA in very low level of blood, or low volume blood. So in the future, if we could develop those types of technologies, even if we're not talking about targetable mutations, you could think of, you could have liquid diagnostics. These are fantastic opportunities for the future. You could monitor.
I do like that idea, especially like the idea that you would be targeting, and we'll come to this topic, minimal residual disease. So for example, what are the mutations in that population or populations that are left after therapy? The persistent MRD, those could be helpful cell populations.
I think the same technologies can be used for many purposes. They can be done to find targets, they can be found to set the diagnosis, they can be found to monitor, they can detect early relapse. It's the same technology, it's just used in different ways.
Right.